Hi and welcome to this multimedia video tutorial on small bowel obstruction. By the end of this tutorial you're going to understand all the different aspects about small bowel obstruction and also how to answer the questions related to it in your exam. So let's crack on and start with an explanation about what small bowel obstruction actually is. Now, small bowel obstruction does exactly what it says on the tin. The obstruction of the lumen of the small bowel, which impedes the passage of ileal contents. In the anatomy of small bowel obstruction, we've got a distal part, a transition point, and proximal small bowel, which is dilated. So that's distal small bowel that's collapsed. Now, in patients with small bowel obstruction, there may be a preceding history of diarrhea, and that's before the onset of absolute constipation once the bowel is fully collapsed. So a distal collapse, a transition point where the obstruction is, and proximal bowel dilatation. Now, in this proximal bowel dilatation, there is secretion of fluid into the lumen. And this can mean very large volumes of third space fluids in your patient, which is why they get dehydrated and hypovolemic. But what else can occur? Well, as you know, along the mucosa of the small bowel, there are lots of bacteria, so anaerobes and gram-negative organisms, and due to the loss of integrity of the mucosal blood barrier, bacterial translocation can occur, causing a bacteremia. And in the case of a strangulated small bowel obstruction, for example in a strangulated hernia, there can be necrosis and gangrene of the small bowel. And if this isn't resected, a perforation can occur. It can lead to gross peritoneal contamination, generalized peritonitis, and if the patient isn't taken to theatre, then death will result. So what causes small bowel obstruction? Yes, you can say there are extraluminal causes, causes in the bowel wall, and intraluminal causes, but I like to think about what's common and what's not so common. Well, the most common cause of small bowel obstruction are adhesions, accounting for around 60% of patients with small bowel obstruction. Now, often this is a result of adhesions due to previous abdominal surgery, but occasionally you'll find patients with congenital adhesions, often referred to as congenital bands. Next most common is malignancy, so that's tumours. Next up is hernias, so certain hernias are more likely to cause the problem than others, so femoral hernias are very high risk. And Crohn's disease, now these can cause strictures in the small bowel, often in the terminal ileum, and if they completely occlude the lumen, then of course you've got small bowel obstruction. But they can also cause an intermittent or subacute small bowel obstruction as well. And then you've got the rarer things, like mesenteric volvuli, where the mesentery of the small bowel twists on itself and occludes the lumen. It can also interrupt the blood supply to the small bowel. And things like gallstone ileus, where a gallstone enters the small bowel and then lodges somewhere in the distal ileum where the lumen diameter is a little bit narrower than the diameter of the gallstone. In children, there are distinct causes of small bowel obstruction that you need to know about. So that will include your intersusception, where one part of the small bowel invaginates into another, causing obstruction of the lumen, pyloric stenosis, and also congenital atresia. And atresia means failure of development of a lumen. So what's in your typical history of someone with small bowel obstruction? Well, this is abdominal pain, that's central and colicky in nature, vomiting, and absolute constipation, which is not just not passing stools, but also failure of passing wind, so no flatus. Now, often these patients may complain of feeling bloated as well. Now, this depends on how much small bowel is dilated, and that depends on at what level the obstruction is. So what about the non-specific features? Well, often patients don't have an appetite because they're too busy vomiting, so they can't take anything orally. And if they have fevers, well, that's non-specific for small bowel obstruction, but in that case, patients may have a complication such as a perforation. Now you need to ask questions to find out what the cause of their small bowel obstruction might be. So ask them if they have a history of abdominal surgery. Ask them if they have a history of malignancy, and of course, they may have a change of bowel habit, some PR bleeding as well. That might point to the malignancy as a cause. And now you need to ask questions to target the differential diagnoses of their abdominal pain. Now there are a whole host of different causes of abdominal pain, as you know, but in someone who's got abdominal pain and is vomiting a lot, then important differentials would be gastroenteritis and acute pancreatitis. Have a look at this set of observations, or vitals if you're not from the UK. Now they can look fairly normal, but often there's at least a borderline tachycardia, and that just tells you something is not quite right. Often, however, there is a degree of dehydration and hypovolemia due to a combination of reduced oil intake, vomiting, and a large volume of fluid often in the proximally dilated small bowel. So these patients can be very dehydrated, and if you haven't already, try to observe a laparotomy for a patient with small bowel obstruction, and you will see just how much fluid is often aspirated from the small bowel, or indeed from the nasogastric tube. We're talking litres, and as we'll see later, these aren't patients for whom you just pop up fluids at a maintenance rate. There's often a significant deficit, and you need to recognise this in order to prevent renal impairment and also the effects of hypoperfusion of other organs too. So have a look at these. What do you think broadly speaking is going on? Well, this patient is septic. There is a significant tachycardia and hypotension, and there is a marked pyrexia, temperature's 38.6. Now, yes, in a patient with small bowel obstruction, this could be due to perforation in a complicated case. Or in practice, in someone this unwell with a distended abdomen, there are many other differentials that could cause the bowel to distend and look like a small bowel obstruction. One of the most important differentials would be ischemic bowel. So when you approach the patient, the first thing that you might notice is that they're vomiting. Perhaps they've got bits of vomit on their gown, or there may be bowls full of it next to the patient. You may find the patient's very dry, with signs such as delayed capillary refill, very dry mouth and dry tongue, and a lowered JVP. On inspection of the abdomen, pay particular attention to the presence of any scars, as this may hint to the cause of a small bowel obstruction as being adhesion related. On further inspection of the abdomen, there may be varying degrees of abdominal distension. Tenderness may be central, but often it is non-specific. Look for signs for local peritonism, and by peritonism I mean guarding, percussion tenderness, and or rebound tenderness. Now once you've done this, don't forget to check the hernial orifices. So that's the femoral triangle for femoral hernias, the inguinal region and the scrotum for inguinoscrotal and inguinal hernias. That's the inguinoscrotal hernias that have a higher risk of obstruction and strangulation. And also if there are any scars, palpate along the scars with them coughing or lifting their head up to see if there are any hernias there too. Now have a listen to the bowel sounds, which may be tinkling. Now yes, I bet you thought I'd forgotten, but no, you really do need to do a digital rectal examination. There may be blood perhaps if there's some mucosal ischemia and ulceration, or there may be a mass and what you've actually got is a large bowel obstruction due to an obstructing rectal tumour. So let's talk about investigations. Firstly, what can you do? Now again, don't forget these 6 simple tests to consider for any patient you see in any scenario. Now try to relate them here to what you might find, what you might look for in someone with small bowel obstruction. Now the first, the capillary blood glucose. Anyone with a systemic inflammatory response may have a raised blood glucose, and particularly diabetics. Next, have a look at ECG. Someone with abdominal pain might actually be having an MI, and you need a baseline because things may go wrong during the course of the patient's stay, and the anaesthetist will probably want to have a look at it as well if this patient does eventually go to theatre. Next up is urine dip. We're trying to look at other causes of abdominal pain related to the urinary tract. Remember, we don't know the patient's got small bowel obstruction. We have to keep other differentials in mind. And in females, then you need to look at the urine beta HCG as well, and this is to make sure they're not pregnant before you start irradiating them. I've listed the usual surgical bloods you need to consider for surgical patients. In patients with small bowel obstruction, an elevated white cell count and CRP may indicate complications such as perforation and sepsis. You need to look at the UNEs to establish the renal function. As we already mentioned, these patients can become very dehydrated, and an acute kidney injury or acute renal failure can develop as a result. Don't forget to check the amylase. We've already talked about how pancreatitis is an important differential diagnosis in patients with abdominal pain and who are vomiting. Your gas is important for establishing just how unwell your patient is and how aggressive you need to treat them and how early on you need to escalate the care. These patients may be acidotic if they're shocked due to dehydration and or sepsis. In particular, have a look at their lactate too. If they've got small bowel obstruction and some of their bowel is also strangulated, then that necrotic bowel is going to push that lactate right up, and you need to do something very, very quickly. And I hope you know this by now, but an erect chest x-ray, have a look, see if there's any free air under the diaphragm. And finally, last but certainly not least, you need to look for some of the cardinal radiographic signs of small bowel obstruction on an erect abdominal film. And that is 1. Small bowel dilatation, 2. Air fluid levels, and 3. An absence of gas distally. So there are our simple 6 tests for any patient that you see. What further tests can we do for patients with small bowel obstruction? So firstly, there's gastrographin follow through. So gastrographin is a water-soluble contrast that you can give orally in a patient and then take serial abdominal films. And you can follow the gastrographin and see if it goes all the way to the rectum to demonstrate that there isn't a complete obstruction. Now, the reason we use gastrographin, not barium, is because barium is quite irritant and has a potential to cause peritonitis if there's a perforation. Sometimes gastrographin is given for its possible therapeutic effects, for example, in reducing the need for surgery in adhesion-related small bowel obstruction. So ultrasound is very good at picking up dilated small bowel and suggesting small bowel obstruction. However, you've often got the diagnosis clinically or in combination with abdominal x-ray, and then the next step is often CT, which will give you a lot more information. So it's often of limited clinical utility. So CT in small bowel obstruction is really very useful. Beware, of course, it involves radiation and the administration of IV contrast, which can be risky. But it can help exclude other differential diagnoses, it can give you the cause of the small bowel obstruction, and it can tell you if there are any complications such as frank perforation or evidence of strangulation and ischemia sometimes too. Although I hasten to add, you only really know if there's ischemic or necrotic small bowel when you're actually in surgery looking at it. There's no surefire way of otherwise knowing. MRI is excellent at trying to find the cause of small bowel obstruction and of course making the diagnosis, but in practice it can be quite cumbersome. Logistically it's difficult. Often it's easier to get a CT, and patients need to be in a confined space for prolonged periods of time, and often these patients really aren't that well. But in particular for Crohn's disease it might be useful because it can look at all of the small bowel and see where there might be stricturing disease, for example. Now, often you're going to get asked the question, how do you manage small bowel obstruction? Yes, the right answer is ABCD approach, but then you need to have a concise way. So you can separate into conservative, medical, and surgical management. Let's start with the conservative management, because this is often what you can do as a junior doctor. Here's Johnny again. Unfortunately, he's looking rather green. He's got small bowel obstruction. He's quite unlucky too, because I think in my other tutorial he may have had pancreatitis. Anyway, there he is with a quite a distended abdomen. He has small bowel obstruction. How are you going to manage him? Well, ABCD approach. We'll just concentrate on the management aspects of ABCD, but of course you may integrate your tests too, such as your blood gases, your bloods, your x-rays, your ECGs in the relevant parts of the ABCD. So concentrating on the management aspects, let's check firstly that his airway is patent. Now do bear in mind that patients who have got compromised GCS may also have a compromised airway, and if they're vomiting, that is a recipe for aspiration pneumonia and disaster. Now, moving on to B for breathing, let's give him some oxygen. Now, what else can we do with his breathing? Now, if he's that distended, he may have some difficulty ventilating the basal parts of his lungs, and that's not going to be very good for him, so we can try and sit him up, and we can also try and decompress his stomach. So we've put an NG tube down, there's a gastric tube, and we're aspirating on that. Now this is the suck part of the drip and suck you may already be familiar with when treating small bowel obstruction. So we're aspirating that NG until it's dry, till the stomach's dry, we can't get anything else back. And once we're happy with that, we'll attach a bag and leave the NG on free drainage. Now we may ask the nurse to kindly aspirate every, say, 2 to 4 hours. Now, that's helping us with B, but it also is important for C because it gives us a guide as to how much IV fluids he may need.
Now remember, there may be a significant fluid deficit, so you need to, when working out how much fluid to give this gentleman, who's going to be nil by mouth for perhaps quite some time, he needs his maintenance fluids and also his deficit and what he may continue to lose. So that could add up to quite a bit. So here we go, we've popped some IV fluids up and put it into a reasonable sized cannula. I've got a green one there. And yep, you've guessed it, this is the drip part of drip and suck. IV fluids, drip. Yeah, pretty simple. So if we're worried about the fluid status of poor Johnny here, we need to really put in a catheter. Sorry Johnny, but if we're not giving you enough fluids, then your kidneys might pack up. So we need to measure your urine output every hour. And if it drops below 0.5 mils per kilo per hour, then we may need to give you some extra fluid to maintain perfusion of your kidneys. So incidentally, look at the colour and quantity of the urine that's come out. It's really dark and not very much. Now there's so much fluid coming in and out from the NG, the catheter, the IV fluids, and this patient's going to be in quite a considerable deficit. We need to have a way of accurately recording this. So we need a fluid balance chart, accurate input and output recorded. And that's C. Poor Johnny with all these tubes coming in and out of him. Well, D is your capillary blood glucose, amongst other things that you'll consider for all your patients, of course. So check the blood glucose, and if it is high, as it may be in patients with systemic inflammatory response, and particularly diabetics too, maybe they've not had their all anti-hyperglycemics because of their vomiting. Now, if it's very, very high, you may also wish to consider an insulin sliding scale regimen. So that's ABCD management, and you know what drip and suck means too.
Okay, so that's conservative management. What about the medical and surgical management of small bowel obstruction?
So medical management is essentially what we've already discussed, plus of course antiemetics and analgesia, and all of this that we've discussed up until now is what you need to do for your patients, including the medical aspects. Here buscopan may also be helpful as it is a smooth muscle relaxant, and so it might relieve some of the pain associated with small bowel muscle spasm. So the surgical management will depend on what the cause of the small bowel obstruction actually is. So for some causes it is the only treatment, for example where tumours are involved, surgery may be required either to bypass the obstruction or to resect the tumour itself. But for some other causes of small bowel obstruction, surgery is reserved for when conservative or medical management has failed. For example, in adhesion-related small bowel obstruction, in which case patients may go on to have an adhesiolysis. Bear in mind that the surgery itself will probably cause further adhesions. Another reason to opt for surgical management in any situation of small bowel obstruction is when you suspect ischemia or strangulation of the bowel. Now bear in mind that any time someone goes to theatre for small bowel obstruction, there is a risk that they will need a bowel resection plus or minus a stoma, but if they have a primary anastomosis, so the bowel ends are joined, then there is a risk of anastomotic leak.
Complications in patients with small bowel obstruction can be early or late.
When you greet your patient with small bowel obstruction for the first time, they may have already perforated, or they may be about to, and this leads to peritonitis, systemic inflammation, sepsis, and death. Now, organ failure may result from the sepsis, or more likely, it may result due to inadequate fluid resuscitation, so the kidneys may not be sufficiently perfused, for example. And don't forget electrolytes. In particular, patients lose a lot of potassium in their gut, and the serum potassium will just keep on falling until you do something about it. The consequence of ignoring it is potentially a life-threatening arrhythmia. Now, late complications here are things that take a bit more time to develop. Having a big distended abdomen will impede the ventilation at the lung bases, and this will lead to stagnation and infection. Venous thromboembolism is a risk in patients who are immobile, with perhaps a systemic inflammatory response of some degree, and especially if they then go on to have surgery. And then with surgery comes all the complications associated with this too.
The prognosis of patients with small bowel obstruction will depend on three things. One, the patient. So if they're old and they've got multiple comorbidities, end-stage COPD, ischemic heart disease, diabetes, they're going to do a lot worse than your fit and young patients with no comorbidities at all. Two, was this a complicated small bowel obstruction? And by that, of course, I mean, Was there a perforation? Was there gross peritoneal contamination? And did this patient have major surgery? Now, if the answers are yes to all of that, then your risk of mortality or morbidity will go up. And 3, prognosis depends on the cause of the small bowel obstruction. For example, in someone who has adhesion-related small bowel obstruction, there's a reasonable chance that they may get recurrent attacks. Indeed, you have some patients who have one attack of adhesion-related small bowel obstruction, settles conservatively, never comes back. But there are patients who come into hospital repeatedly with attacks of small bowel obstruction. Well, we're at the end of the video now, so let's just recap on what we've learned. Firstly, small bowel obstruction is obstruction of the lumen where you get distal collapse and proximal dilatation. So patients present with abdominal pain that's central and colicky, vomiting and absolute constipation. Often they will also be bloated. On examination, you might find these patients dry like a crisp, and when you go near them you'll find they're vomiting and there's vomit bowls and it's not very pleasant. On examination of their abdomen, they may or may not be distended. They may have mild or moderate non-specific tenderness, but if they've got severe tenderness with peritonism, then you need to suspect a perforation. Don't forget to examine the hernial orifices too. Investigations, don't forget those simple 6. Now in particular we'll touch on the abdominal film. Remember the signs of small bowel obstruction. You might find all or none of them, okay? So that's small bowel dilatation, air fluid levels in the small bowel, and an absence or paucity of gas distally, i.e. in the large bowel. How do we manage these patients? There's conservative management, medical management, and surgical management. And how do these patients do? That will depend on the patient, whether there was a complicated small bowel obstruction, i.e. a perforation, and 3, it will depend on the cause as well. I hope you've enjoyed this. I hope you've learned a lot. Good luck for your exams. See you soon. Bye bye.